Hey, well, good afternoon, everybody. I'm really happy to maybe launch our discussion today, dialogue on disparities. We're roughly we're now over our we're about right about the halfway point in terms of participants, at least those who said who would be who RSVP'd. So I'm going to use that as my marker to start, and I'm sure we're going to get many more who will be joining us as they navigate probably from other Zoom meetings. So again, welcome everybody. So I'm Ken Smith. I have the privilege of directing Nexus and the Wasatch Front Research Data Center, and it's really in my role as with Nexus, where we're promoting team science, as to encourage a number of topics for discussion that will promote team science, and certainly social disparities is one of those very important topics. So I'm just going to give a little bit of background about how we got here, and then I'm going to introduce our Senior VP, Dan Reed, who will make a few remarks about this topic and the university's focus. One of the things I would just ask everybody maybe at the outset to just please make sure that your mics are muted, and just for courtesy for the presenters. So what we're hoping to do today,
participants specialize in
yeah, I want to make sure everybody
so, you know,
can make sure
make
sure everybody mutes their mic, please.
You know, they always have.
Thank you. So our objective today is to really facilitate cross-campus and community engagement on research, on this broad topic of diversity and disparities. And it's a very large landscape. And but what we want to do today is hear from we have two great presentations that you've seen advertised, and but at the end, for those who can stay on, we want to have some breakout groups to talk about grant ideas, and so that's what we're going to focus mostly on after the presentations. And we hope also to, for our Nexus to be able to figure out how we can help coordinate with you about your grant proposals and your ideas. I just want to remind everybody that you can see on your screen that that we are recording. So just to be mindful of that, and again, just mute your microphones. So maybe what I'd like to do next is to
does anybody look at their
introduce. We have it's interesting, we have the discussants preceding the presentation, so that's a novel twist. So I appreciate the innovation. So I would like to Dan told me to keep it very brief, so I'm just going to say that Dan Reed is our Senior Vice President for Academic Affairs at the U. I think most everybody on the call knows Dan or knows of him, and I think in the interest of time, I'll just introduce him that way. And I am really pleased to know that how much the university and his office are promoting the Equity, Diversity, Inclusion, the EDI initiative. And so, Dan, I'll just mute myself and allow you to sort of give your remarks before we turn to the presentations. Thank you.
All right, thanks, Ken, and thanks to you and Cindy and everyone else just for a chance to say a few words. You know, this is a topic that I think, as Ken rightly said, has risen to top of mind. Frankly, it should have been top of mind for all of us for a long time, but circumstances have certainly elevated it in importance and immediacy. And it's something that I think is reflective of actually what a holistic One Utah leading public university ought to not only be thinking about, but doing something about. And one of the things that's true about these disparities that we've really seen in COVID has brought it to the forefront in some new ways, is that there are huge and systemic disparities in just about everything that one might think about. It's certainly true in, for example, the effect of COVID on different populations. And so there are some health disparities and wellness disparities. It's had disproportionate economic impacts adversely on many groups. It's had disproportionate educational impacts on multiple groups. And of course, connected to all of this are the deep and ongoing issues around social justice. And if you think about what those things really collectively are about, now we think about engaging our communities, those are precisely the things that a One Utah perspective can really bring. And that's what I know Ken and Nexus are trying to facilitate. But what it means is we have to think holistically, in my mind, about education. So there's some profound issues about how we illuminate 360 perspectives on these issues, because whether it be health outcomes built to natural environmental disparities, which contribute to health outcomes, economic disparities, educational disparities, those are all deeply intertwined. And so touching on just one piece without looking at the others misses the interdependence and why the issues are so persistent and so pervasive. So I think it's a great example of us thinking about how we, for example, think about thematic education, what it means for how we teach our students and integrate topics across courses. But I think more profoundly, it's what is our moral and social responsibility as a public research institution to rally together, to think not only about the research and scholarship issues, but the pragmatics of how do we actually make a difference. So as important as the research and scholarship we engage in the end, the impact of ideas is how do they build a better world? And that means that we have to approach these problems with some humility and recognize that we have to work with our community partners to understand what things can and will make a difference. And so one of the things that we're talking about across the U, in fact, I have a meeting a bit later today to talk about some more with Mike Good and Andy Wyrick, is how we think about an initiative on campus to help us build a fair and equitable society. And it is about these pillars, about social determinants of health and wellness, about social determinants of educational outcomes and access, about social justice, and also about environmental issues, as I said, built and natural. And then, of course, how all those things connect to opportunities for socioeconomic mobility and prosperity. And one of the things that's worrying to me in our country is that the mobility of our population is increasingly constrained. If you're born in one of the bottom economic strata, the statistical odds of you escaping are increasingly low. And that is deeply troubling. So one of the things that we're talking about, and the parameters are yet to be determined, are how we think about those things as a campus initiative. One of them might be theme semesters, where we rally people across campus to bring speakers and discussions and other events to look at these interdependent issues. One is how we might think about collaborative teaching across disciplines and colleges to engage our students in debate and understanding on these, seed funding for some initiatives, and then possibly some thematic cluster hiring, where we think about building on our strengths and adding cadre of faculty who can work together across campus and with our communities to address these issues. So those are the things that we're working on. I hope we'll have some announcements later this year about that. And so this meeting is a great sort of kickoff for many of those kinds of discussions. What can we do? What are the best approaches? And how can we make a difference? And I've said in multiple contexts, as you can tell, I'm missing a good bit of hair as I get older. I care more about what do we do that's actually going to make a difference, not just talk about problems, but actually solve them and move the needle to build, as I said, a more fair and equitable society. So everyone has an opportunity and their future is not defined by the zip code where they were born, which sadly is too often true right now, as Ken's analysis and many of your others will sadly reveal. So that's the challenge before us. And I look forward to the presentations and the discussions. We can make a difference. Step one is deciding that we want to. So thanks for a chance to say a few words, and Ken, back to you.
Dan, thank you. That was great, and it's really encouraging and heartening to know the importance and emphasis that you're putting into this effort with the potential cluster hires and possible funding in themed semesters. Those are really great, and we'll look forward and we'll hopefully participate in a very fundamental way in all those initiatives. So again, thank you for joining us and for those remarks. So let me go ahead and thanks again. And I will, I'm just gonna then turn to the next part of our program, which is to introduce our speakers. Our first speaker, I'll introduce now, is Dave Wetter. And then after his talk, and I see our second presentation, they will be joining us close to the time when we think Dave will be concluding, and I will introduce those speakers when they join, and I'll keep my eye on for when they join. But I'm going to turn things over to Dave Wetter. I just, for those of you who don't know Dave, and I can't believe that all of you don't know Dave, but Dave is a John M. and Karen Huntsman Presidential Professor. He is a director for the Center of Health Outcomes and Population Equity, HOPE, and that is going to be a centerpiece of what he'll be talking about today. And he also serves as a senior director for community engagement and cancer health equity, also at the Huntsman Cancer Institute. And I have the privilege of being one of the many investigators up at HCI, so I've had a chance to rub elbows with Dave over the years. And Dave, I'm going to go ahead and turn it over to you. And I think you have control over your slides and moving through them. So welcome, Dave, and thank you again.
Thank you. Let me see if I can do this. Hold on here. I'm going to do one thing first. There we go. Now I think I got it. All right. Are folks seeing my slide? Ooh, I conquered technology. That's actually one of my biggest challenges. So it's really a pleasure to have an opportunity to chat with you a little bit today about the Center for Hope from the same place I've sat for the last 8 months in my office at home. Ken mentioned team science, and we sort of frame it a lot about the work we do about partnership, because it's the only way we're going to impact health inequities in the real world. And Provost Reed, I think, said, about 4 words that sum up our entire mission, which is build a better world. So I'm going to talk to you a little bit about the center overall, if I can figure out how to get my slides working. And give you just a brief overview of what we're all about, and then take you through one example of the kind of research we do, and then finish up by just showing you some of the partnerships that we've created, because again, it's the only way our work is going to actually have an impact on the real world, is if we go out there and engage real world partners. So this is a statement that NIH put out probably 15 or 20 years ago, and it is on the website of every single implementation science, health inequity kind of center program you'll find, which is, we know what works. We have a ton of things that work. We don't get them out there into the real world, into the settings that reach the people most in need. When we do get interventions, treatments out there, it's incredibly common that we miss vulnerable populations. And so because of that, the Center for Hope's mission is to serve as a research infrastructure that brings communities and researchers together to create long-term solutions to prevent cancer and chronic disease. And I actually can see that I need to update my slide because we've now got a big, huge project on COVID-19, which is obviously doesn't fit in either one of those, to improve health among underserved populations. And so I came to Utah about 3.5 years ago, and we've worked in a number of different areas. Health inequities is the cornerstone of everything we do. Implementation and dissemination of evidence-based interventions, behavioral interventions. We do a lot with technology, from EHR kind of modifications to mHealth to health information technology more broadly. And our focus is on low socioeconomic status populations, minorities, and rural frontier populations. We also have a training mission because, I hate using trendy terms, but folks I've heard, force multiplier is a really trendy term, but, that's one of our goals, is to train young scientists to go out there and address health inequities and social justice, so that this work just gets permeated into everything that we do. Partnerships. I realize I need to update this slide too, as it's old now too, but the things shown in black are some of our academic partnerships. Everything in blue is our community partners. And those range from community organizations to state organizations to lots of healthcare systems, and particularly healthcare systems that serve the poor. So I'm going to flip right through this, but it just shows how this work really takes an enormous number of partners. It really is team science. I'm a clinical psychologist by training, but all our collaborators are engineers, computer scientists, computational modelers, primary care physicians, nurses, public health officials, etc. So it's really a really diverse group of individuals that we work with and organizations that we work with. So I'm going to take you through just one example of what's now called implementation science. We've been doing this for a long time, back before it was called implementation science. So I always sort of giggle when I start to see the new terms that come along to describe what we do. But I'm going to take you through the very first grant we got when we got to Utah, which is around tobacco use, where I've spent a lot of my career doing work. And the reason I got started in doing tobacco use, it is the leading preventable cause of death and disability in the US. It remains today the leading preventable cause. Up at Huntsman, we could eliminate about 1/3 of all cancer patients if we could eliminate tobacco use. And we all think that major public health problems are the opioid epidemic, alcohol use, murder, suicide, risky sexual behavior, auto accidents. Tobacco use kills more people every year than all those causes combined. It is an enormous public health burden. It's still highly prevalent. 1 out of every 6 US adults is a smoker. 1 out of every 10 Utahns is a smoker, and we have the lowest rate in the country. And we often pat ourselves on the back for that. And I'm going to be really blunt in that the Church of Jesus Christ of Latter-day Saints is really good at tobacco control. The rest of the state, if you're not in the LDS church, the prevalence rates for tobacco use are equivalent or higher in many subpopulations across the state. So it's not that we do such a great job as the state, it's that the church does a great job as a state, in the state. So what is really critical, though, is that when we do a good job of addressing major public health issues like tobacco use, is we have major declines in deaths. So with respect to cancer deaths over the last 25 years, the American Cancer Society estimated that about 75% of that decline was due to the fact that we drove the prevalence of tobacco use from about 40% in 1960 down to about 13% now. It wasn't because we had new drugs. It wasn't because we had new cancer treatments, surgical approaches, et cetera. It's simply because we drove the prevalence of tobacco use down tremendously. So it's typical, the reduction in tobacco use is typically listed as one of the top 10 public health achievements in the US in the last 100 years. but it had some really, really unfortunate consequences. And I'm going to walk you through what those are. And these consequences are not unique to tobacco. They happen in virtually every single advance we have, whether it's new drugs, new treatments, new policies, new public health approaches, is that we actually increase health inequities. And so this is a graph that shows the prevalence of tobacco use from over about a 50-year period, mid-60s to about 2015. And it simply shows the prevalence by educational levels. So can you see my mouse? Oh, great. So the blue line here is folks that have less than a high school education. Red line have a high school degree. Green line, they've got a little bit more than high school, VOTEC, some college, and purple is college grads. And so what you can see has happened in that 50-year period is that the relative risk of smoking between the lowest and the highest groups went from 1.2 to 3.5. And the absolute difference in percentage points went from 7 percentage points to 17 percentage points. So as we had this amazing public health accomplishment, we increased health inequities because we did not pay attention to underserved populations and vulnerable populations. And so what we've now created is a situation where tobacco use is concentrated in low socioeconomic status populations and populations that have other vulnerabilities such as substance use disorders, other mental health disorders, et cetera. So there's been a number of reviews that show that when we do these non-targeted programs, we actually increase inequities, but that if we target appropriately, we can actually reduce inequities. So the goal, one of our major goals, is to use technology to ensure that as we have advances, that they reach underserved populations. There's a huge digital divide, as people know about at an individual level. There's probably even a more pressing and larger digital divide currently between healthcare systems, between high resource systems and low resource systems. And I'll kind of hopefully chat about that just a little bit later on. So let me just tell you a little bit about helping people quit smoking. The vast majority of smokers want to quit. Over half attempt to quit each year. Only about a quarter use any kind of evidence-based treatment, and consequently, just over 5% are actually successful every year. So kind of a good news, bad news situation. Folks want to quit. They just need to be able to get what we know works. We're incredibly fortunate in the tobacco control field in that we have a resource that virtually no other major public health issue problem has, which is we have a free resource across all 50 states, all Canadian provinces, where individuals who use tobacco can get free help in quitting. And they can get it via phone counseling, they can get it via web, via text messaging, via apps. Many, many quit lines provide some form of free pharmacotherapy, such as nicotine replacement therapy. Numerous meta-analyses have shown that quit lines work. They address a number of barriers to accessing treatment versus our old model, which is where people had to come physically see a provider, a clinician, et cetera. Now they can do all of this remotely. Every quit line offers services in Spanish, and many states that have high populations of tobacco using populations that speak other languages will provide services in those languages too. So for example, California provides services in a number of different Asian languages. So tremendous resource, and only about 1% to 2% of smokers get it every year. They don't know what it is. They don't know about it. We've not done a good job of being able to link individuals, entities, organizations to be able to connect with quitline services. So one of the ways that, and one of the things we've tried to focus on is really developing these partnerships. And we focused on healthcare systems because 80% of smokers see a primary care provider every year. So they're getting in to see a primary care provider. And the healthcare systems are obviously have a lot of advantages to other entities in that they have an infrastructure for being able to assist in the delivery and dissemination of evidence-based treatments. And so this is a really promising avenue for disseminating evidence-based approaches to tobacco cessation. There are challenges. Mainly, we've been trying to do it for about 40 years with a variety of different approaches, and we have failed miserably. We started with something called the 5 A's. It sort of morphed into something called Ask, Advise, Refer a number of years ago, none of which have been very successful. And there's reasons for that. There was a great article in the American Journal of Public Health a number of years ago that noted that if primary care providers tried to do what they were supposed to do as recommended by the U.S. Preventive Services Task Force, they would spend 7.5 hours a day addressing those things and never addressing the presenting problem. So we cannot ask clinicians to do everything they're asked to do. We have to figure out ways of making the right thing happen automatically by default. So that's one of the things we've been trying to do, because one, even when it's hard to get primary care providers to make a referral, and even when they do, patients typically don't follow through on the referral. And I'm just as guilty as everyone. I've got numerous referrals I'm supposed to follow through up and have never done. So, and I'm in the healthcare system. So there's a lot of reasons that trying to address preventive behaviors in primary care faces a lot of barriers that need to be addressed. So probably about 15 years ago, we got approached by Harris Health, which is the safety net healthcare system for Harris County in Texas. Serves over 4 million people. It's the 3rd largest county in the country. It's an enormous system. And they asked us, they had a tobacco cessation program, and they asked us for help in getting more patients into their tobacco treatment program. And so we went in and worked with them, and we figured out that they couldn't handle the demand that we thought we could create. So we convinced them that we should not get their tobacco users into their treatment. They were treating about 200 people a year for a patient base of over 1 million. So terrible, engagement rates. And we came up with something that we called Ask, Advise, Connect, which was simply using the electronic health record to automate and streamline the process of assessing tobacco use, prompting a clinician or a member of the clinical team to provide brief advice to quit, and connecting patients with evidence-based tobacco cessation treatment. And I include this easy button because one of our partners, after we had run the trial, and where I'm going to show you the results, gave us this because that's how he characterized Ask, Advise, Connect, is it just makes it easy. And that is the key in primary care. You want the EHRs are typically set up so that the wrong thing happens. You can change the defaults, make it the right thing, and dramatically change behavior. So we developed Ask, Advise, Connect with Harris Health. And then we partnered with 2 different healthcare systems to test this approach. And we were in Texas at the time, so we were connecting with the Texas Quit line. And our first healthcare system was a very traditional one that Kelsey-Seybold. Think Intermountain, think UHealth, very similar kinds of things. Harris Health is the safety net system, so they'll treat you regardless of your ability to pay. They used to treat you regardless of your documentation status, which was important in Texas. So it's a huge system, treat a very diverse population, well over 80% minority, and about half uninsured or living under the poverty level. So very diverse, underserved. And here we were not trying to improve upon tobacco cessation treatment. The goal was not to make a better treatment. The goal was to develop interventions that would engage people in treatment. So this is now, we have this resource that works. How do we get people to actually use it? So that was our focus. We did 2 randomized clinical trials. Both of them were pair matched group randomized trials. We ran one at Kelsey for 9 months. We ran one at Harris Health for 18 months. And we randomized clinics to one of two approaches. At the time, the nationally recommended standard of care was called Ask, Advise, Refer, where you systematically assess tobacco use, you advise patients to quit, and then you refer them to treatment. And typically referral consisted of handing them a referral card for the quit line with the number and the website and all that stuff. In Ask, Advise, Connect, we did the exact same thing. The only thing we did that was different was that rather than giving them a referral card, we simply had the EHR send their patient information to the quit line, and then the quit line proactively called the individual. And I can talk through, we did a lot of clinical workflow analysis to come up with this, and it takes away a ton of all these multiple little barriers in workflow that prevent the right thing from happening. And I'm not going to go through those just in a matter of time. And so we ran our trial at Kelsey-Seybold, and here's what we found. We found that in the nationally recommended standard of care, Ask, Advise, Refer, less than 1% of tobacco users received evidence-based treatment. Less than 1%. In Ask, Advise, Connect, we got 7.8% or almost 8%. So with odds ratio of over 11, a 13-fold increase. I've developed a lot of interventions over the year, many years. Many of my interventions fail miserably. This one did not. This one worked better than anything we had ever done, and it was the simplest thing we had ever done in our life. So really profound impact in Kelsey-Seybold, and we were super excited about it. We're doing the Rocky Victory Dance, but now we need to know, how does it work with the populations that really need it, with Harris Health. And in Harris Health, we ran the study, we assessed over 112,000 patients, about 18,000 smokers, and we did even better. We got about exactly the same rate in Ask, Advise, Refer. We got almost 15% in Ask, Advise, Connect. So an odds ratio of over 32. I'd never seen that in any work we had ever done in any way, shape, or form. 29-fold increase. And 15% is actually about the best you can expect to get in terms of engaging tobacco users in treatment, for two reasons. The first is that only about 10 to 20% of tobacco users are ready to quit in the next 2 weeks to 30 days at any one point in time. The other is that quit lines require that they be willing to quit within the next 30 days as part of their eligibility criteria. So this 10 to 20% rate, we're maxing out about what you could feasibly expect to get. So we were very fortunate in Texas in that they have a number of funding mechanisms for actually doing sort of demonstration projects. So we were able to get more money to actually disseminate this program to a number of different settings. And what we found, our RCT results showed this 13 to 30-fold increase. And then when we did the dissemination studies, we found that we continued to get an incredibly high engagement rate of 12%, which is higher than any other program that we're familiar with. And really critically, there was equivalent engagement regardless of whether individuals spoke English or Spanish. And that's where a lot of interventions fall down, is they lose their potency in either minority populations, other cultural groups, other languages, etc. And so here we actually maintained the same rate of treatment engagement. And then in these implementation and dissemination projects, we actually assessed abstinence as well. And we found that we got in these populations that are proactively driven to the quit line, we got equivalent quit rates to what the quit line typically got. We saw very strong treatment dose responses associated with cessation. So the more calls they took, the more likely they were to quit. You don't know the direction of effect, of course, but and then the really phenomenal thing is that we actually saw that the Spanish-speaking smokers were more likely to take more calls and were more likely to quit than the English speakers. So really, for us, exciting results, because we've got an intervention that works, and it works as well or equivalently across the two major groups that we were trying to serve at the time. So, moving on 10 years, Ask Advise Connect is now a best practice of CDC. We've implemented this all over Texas. It's been implemented all over the country by other people. And we're not the only people that have done this kind of work, which is often called e-referral. It's being implemented all across the country as part of an NCI initiative at Cancer Center Society, called the Cancer Center Cessation Initiative. So, there's really, really good news, but, 85% of smokers didn't get into treatment, right? They didn't quit. So even though we did about as well as we could expect, we still have a huge number of smokers that are not getting into treatment. So we did some follow-up work and we did a study. Our next study with Harris Health was the only way you got in the study was if you didn't want to quit. So you had to be unmotivated. And so we learned a bunch of cool things. So three key findings from the AAC work and some of our follow-up work. AAC works. The second thing we learned is that, motivation is not stable. Motivation fluctuates up and down all the time. Every single, Monday, I am going to eat better. Every single Monday. But all hell breaks loose, and then I'm not motivated on Friday. I don't want to ruin the weekend, but come Monday, I'm ready to do it again. So that's the way human beings operate. Our motivation goes up and down and up and down. So we found that on one of our control groups for this unmotivated smokers, that over the course of 2 years, just by offering treatment 5 different times, we got about 20 to 25% of smokers to engage in treatment among folks who were initially unmotivated. So it's just catching them at the right time. The other thing we learned is that if we do a little bit of sort of counseling, coaching, navigation, whatever you want to call it, using some sort of motivational engagement principles, that we could get another 10 to 15% to engage over and above just repeated offers of treatment. So now we're starting to get a much higher proportion of tobacco users into treatment. And we got to Utah, and what we did is that we wanted to take what we'd learned in Texas and partner with individuals here in Utah and entities here in Utah to see what we might be able to accomplish. And so what's come out of that is a project called Quit Smart Utah, which is really bringing together what we like to think of as some of the big players in tobacco control in the state, and those entities who are addressing health inequities. And so we've partnered with Utah Community Health Centers, and I'll tell you a little bit more about those in just a moment. Those are all federally qualified health centers, for those of you who know what those are. But basically, CHCs serve you regardless of your ability to pay. We partnered with the federally designated primary care association for the state, called the Association for Utah Community Health, or OUCH, which when I got here, I thought was an unfortunate acronym. And then after a while, I realized that people kind of liked it, and now I kind of dig it too. So we partnered with CHCs, with OUCH, with the Utah Department of Health, and then with a bunch of really phenomenal colleagues here on campus at the U. And we were really fortunate to get one of PCORI's big grant programs called the Pragmatic Trial. And what we're trying to do in that trial is to, sorry, my phone is, of course, as I'm doing, there's people knocking on my door, my phone is blowing up. So if I look distracted for just a nanosecond, that's what's going on. But our goal is to implement and evaluate practical, scalable interventions to increase engagement in evidence-based treatments for tobacco cessation. And we wanted to do that in the populations most impacted by tobacco use, which you'll remember from an earlier slide, are low socioeconomic status populations in particular. And so we partnered with community health centers in Utah. And community health centers, again, serve you regardless of your ability to pay. There are 13 CHC systems with about 58 clinics in the state of Utah. They are all completely independent healthcare systems. They're not one big integrated Intermountain. So it's a really an act of goodwill, collaboration with everybody when you pull these groups together. And the reason, though, that CHCs are so critical to addressing health inequities is the populations they serve. In Utah, the CHCs serve a population that's about half Latino, almost 10% Native American, 37% best served in a language other than English, which is almost exclusively Spanish in Utah. Those of you who know what the federal poverty level is, it's $24,000 for a family of 4. If you make $25,000, you're not under the poverty level and you're supposed to be able to support your family. And so it's an unbelievably low level. 2/3 of the patients at CHCs are below the federal poverty level. Half are uninsured. CHCs go into rural locations that I'm going to piss people off, that UHealth and Intermountain won't go. They have a CHC in Green River, Utah. There's 900 and some people in Green River, Utah. That CHC serves over 1,500 unique patients because patients come. Those of you who've driven to Moab, right? There's nothing else around Green River. So that is the only place to get healthcare. And community health centers go to those places that desperately need some form of healthcare where you wouldn't expect the big dogs to go. So they're really a phenomenal partnership. And just real quickly, so what we're doing in Quit Smart Utah is we're doing what's called a sequential multiple assignment randomized trial. That it consists of 3 phases. In the first phase, we just implement Ask Advise Connect in all the clinics across the state. And we look to see whether people engage with the quit line. And if they do, hallelujah, we've done it. That's what the goal of the project is, to get them into treatment. And we're done. If they don't engage in treatment, we randomly assign them at the patient level to either get text messages or to the continued kind of clinic only, connect only condition. And the reason we're using text messages is because we want to conserve scarce resources. And that's what smart designs are good at doing. If you pay for text messages, you can typically pay for text messaging at 3 to 10 cents a message. If your healthcare system has a population health management tool, texting your patients is generally free. So now you have the ability to make repeated offers of treatment over and over and over at a very, very low cost. You can send 10, 12 messages over the course of 6 months for a quarter. You know, what cheaper way to reach patients? And so we worked very hard with a patient advisory committee and a study advisory committee that consisted of clinic representatives to design the text messaging approach. And we follow people for 6 months to see if we can get them to engage in treatment. And if we do, again, hallelujah, the project has worked. We're done. If the patient doesn't engage, we randomize them a second time, and we randomize them either to get just continued text messaging, because it may be that we've not done it long enough. We've not hit them at that right moment when they're ready to make a quit attempt. And we can remember how cost effective this is. So it's a really cheap way to keep reaching out. Or we randomize them to text messaging plus something called MAPS, which is an approach for talking to patients that we've developed in low socioeconomic status populations over the last, how long? 15, 20 years. And because we know that just a call or two can often help people address some of the last little remaining sort of barriers that cause them to not engage in treatment. So we have then, after getting this Quit Smart Utah, we were all just, ouch, CHCs, UDOH, us, we're just so enjoying, loving, working with each other that we've been able to really parlay that set of partnerships into a bunch of other grants as well. And I want to make a really key point here. is that, and the topics we've addressed have been driven by our partners. If you want to make change in the real world, if you focus on your partner's priorities, your life will be a hell of a lot easier. You will get a lot more buy-in. And so when we got to Utah, they told us their top 2 priorities were tobacco use and colorectal cancer screening. We now have grants there. The second year we asked them was the opioid epidemic. We brought in Julie Fritz from the College of Health to collaborate with us, and Julie's got a grant with those partners addressing opioid use. An ongoing priority for them was HPV vaccination. We've now got funding there. And then obviously in the last 6 months, COVID-19 dominates everything. The healthcare system world and the low resource healthcare system world in particular has just been turned upside down. And so we were really fortunate to get one of those NIH called RADx UP. UP stands for Underserved Population Grants. So this is only a 2-year grant. It's a phase 1 and a phase 2. And phase 1, we're focused completely on increasing screening and testing uptake. And then NIH will release phase 2 in a year or 2. And we hope that it will be about vaccine dissemination. And we hope then that the program we've developed with this set of partners will be able to serve as a vaccine dissemination, because the last people to get the vaccine are going to be low socioeconomic status, uninsured, folks that dramatically need it, working in essential jobs, working in jobs where they can't work from home, working in jobs where they can't take 2 weeks off or they'll lose their job. So we've got that set of partnerships, and then more recently, we've really we feel like we might have saturated the poor community health centers here. So we're working now to actually build this out to around the rest of the Mountain West, and by that we mean Idaho, Montana, Wyoming, and Nevada. And we've been able to start getting some funding to address some of the issues that they're facing. And the really exciting thing about that is, rural and frontier populations are really getting enormous amount of attention from NIH right now and from HRSA right now. And so this will dramatically increase access to rural and frontier populations relative to what you have in Utah. And the other thing, it's like, the University of Utah and those 5 states I mentioned, we are really by far the big dog in terms of an academic institution with, a medical school, all the health sciences schools, a flagship university, a Pac-12 university, a comprehensive cancer center. We're the only one of virtually all of those in that 5-state region. So it really gives us an opportunity to expand our impact. And I'm going back to, I love that Provost Reed started that, build a better world that goes beyond just thinking about the state of Utah. And so that, I will be happy to take any questions. I don't know how long I took, Ken. I know I had 30 to 40 minutes. I probably went a little long on my 30 minutes, so I apologize.
Okay, Dave, thank you very much. Really such impressive work, and we're glad that you're able to share what, I've never seen relative risks over 30 either. So I either it's amazing work or it's fake news. So I think it's amazing work. So in the interest of time, maybe if we have time for maybe one question, so we can give our second presenters their allotted time. If anybody has one quick question, they can. Well, let me just open it up and see who gets there first, and then I'll probably move on after that one question. Does anybody want to pose anything to Dave? And if not, we can certainly do that by email.
I apologize. Feel free to email me, anybody. I apologize. I'm late for a strategic planning retreat.
Oh, okay. Well, maybe then I hadn't realized that, Dave. So I'm not trying to cut you off, but there's with your work generates so many questions, and I think the the focus of our event today is also to generate ideas and collaborations. And it's really your kind of final point about trying to make sure that there are opportunities and you're reacting to what people are doing out in the community. So maybe that should be the, that should be the enduring message from your talk as well. And so maybe I'll just let people reach out to you. But Dave, I'll let you get to your meeting that you're perhaps late to, and I really appreciate you taking the time on this amazing work.
Thank you. I appreciate it.
Okay, thanks again, Dave.
Bye-bye.
Okay. All right. So I just wanted to remind everybody, some people have joined us after I made some announcements. Just make sure that I always like to repeat that, make sure that you mute your mic, and also to remind people that we are recording this. So, and then I want also to remind people who can stay on that we are going to have breakout groups to talk about projects. And no, I'm not handing out money at the end of this, but we do want to talk about grant opportunities and funding and in this domain. So I just want to repeat those comments. So let me introduce our next speakers. This will be a tag team. And so we have now on our Zoom conference, we have Trent Alexander and Katie Genetic. And so Trent is, some of you may know Trent is Associate Director and Research Professor at ICPSR, our favorite data source other than Utah Population Database at the University of Michigan. And Trent is a historical demographer and has been doing some amazing work with data infrastructure and on the census and linking that you're going to hear about. And Katie, some of you also will probably know, she has been on our campus a few times, and apparently she likes us because she's back for yet another one, and we're really happy to have Katie here joining us. Katie is an economist working at the Census Bureau, and she directs the census's longitudinal infrastructure project known as CLIP. She has also been supporting the Federal Statistical Research Data Centers, of which we now have one, yay for our side. And Katie was one of our informants and counselors on as we put that proposal together. So they're going to be talking about this really interesting project on data linkage that I think for those of us interested in social disparities, big data, social mobility, I think you're going to find this very interesting. So I am going to mute myself and turn it over to Trent, and I'll let you take it away, Trent. Thank you.
Okay, thank you. Ken, can you see my presentation on the screen?
Yes. Yeah.
Okay,
crystal clear. Yep.
Okay, great. So yeah, thank you for that introduction. I'm Trent Alexander, and Katie Genetic and I are both going to talk a little bit. So I'll be doing the first part here. I really appreciate you all coming. We're thrilled to have an opportunity to talk to this group. This is a project that we've been working on in many ways for the past 15 years, but we just, through different pilot projects, but within the past year, we have just gotten funding to really do it. So the big picture of what we're doing is we're creating an infrastructure of linked census data from 1940 through the present. This will be person-level linkages available within the research data centers. And bigger picture, this will be going all the way back to 1850 because of work that Ken and others are doing with the 1850 through 1940 censuses. So that's kind of the vision, is linked census data from 1850 to the present. And the last talk I know was very focused on social disparities research. This will be, we hope, a really unique and special tool for studying population subgroups over the long term. So this is more about a tool that we hope you all and people like you will use. This will facilitate social disparities research. And we're going to talk about some ways that researchers have already used this tool, because much of it is already available. We are extending it. This is something that people were working on before us, and we're going to kind of bring over home plate, we hope, but this has been involved many people at many locations. Okay, so we're going to talk for just a few minutes about how we got into this of linking person level census data, and then go into a little bit more detail about our efforts to expand the existing infrastructure. Specifically, we have brought the 1940 census into this infrastructure of modern census linked data, and we will soon bring the 1960 and 1990 censuses through 1990 censuses into this infrastructure as well. We'll conclude by talking about how you can already get some of this data and when and how you'll be able to get the rest of it when it's done. I, probably like some other people here, have been working with individual level census data from the old days. This is not me, but it may as well have been. I started using person level data in the 1990s at Carnegie Mellon University for my dissertation, where I was using what was the only person level census data available at that time. This is public use microdata samples. These were samples of the censuses that the Census Bureau had made from 1940 through 1990. And in the mid 90s, it was all the rage. It was really, really hard to use, but it was what you wanted to use if you were doing cutting edge historical demography. And I used it, and it was a huge hassle. I loved it. I loved the hassle of it, to be perfectly honest with you. And I maybe even loved that even more than I loved the research I was doing with it. And what I learned as soon as I finished, well, in the course really of my dissertation, is there was a larger group of people who also loved the hassle of it at the University of Minnesota. So if you've heard of the IPPMS project, this is where I went as soon as I finished my dissertation. I worked there for 10 years. Katie also worked there for about 10 years. We had some overlap where we worked together, and that's how we've started working on this longer term, this larger project that we're describing to you today. What they did at that time and what they do now, although they do a lot more now, was made it easy to use all these different public use microdata samples together, because things change from year to year in ways that aren't important, but that can really, really mess up a researcher. Just variable names, variable labels, values. If male is 0 in the sex variable in 2 years and 1 in 2 other years, that's just a hassle that costs you time. And it can also introduce error. It's a much bigger hassle for variables like occupation or industry, where there really does need to be some qualitative work to make sense of change over time. That's what we did at the IPPMS. We made sense of all this data over time to facilitate long-term studies. At the time, IPPMS was mostly historians and historical demographers. Now they've sort of branched out in many directions. So I loved it. The thing there that kind of set me and Katie off in the direction that we have ended up in was in the early 2000s, after the 2000 census PUMS was released, the public use microdata sample. We were thrilled, we integrated it. And at the same time, the Census Bureau released a full count internal microdata file within the Census Bureau, not PUMS, all the cases, which blew our minds. So we inquired, well, what about the 1960 through 1990 data that you made PUMS with? Can you release all of that internally? And they said, well, let us check if it's still machine readable and available. Most of it was, and they immediately released it. So people, probably many people in Utah, but many people at all the research data centers are using that. There was one exception. The 1960 census was not fully machine readable. At that time, all that data was stored. They weren't reel-to-reel tapes. They were 9-track. They were some sort of magnetic product, but it was not a tape. And they degraded because reel-to-reel tapes, magnetic tapes, these are not archival quality storage media, and the data didn't last. So some of the 1960 census was unrecoverable, and we wrote a grant proposal to the National Institutes of Health to recover it. So Katie and I both worked on that project. It was stored, the complete 1960 census manuscripts were stored in a cave in the National Archives in Lenexa, Kansas. So that's the picture you're looking at is from when we started that project. It was so exciting. There's all kinds of great government documents stored in this cave because it's cheap, it's temperature controlled, it is a great place to store things. It is not a thoroughly modern facility. It was a fine place to work. It was actually dry when you got inside. This was just the entrance, but you can see it's also very truly a cave. And the 1960 census microfilms of the actual manuscripts, they were stored on, I think, about 20,000 microfilm reels, of which we needed to scan 2,000 to recover the cases that had been lost, that were on the media that was unrecoverable. And the 1960 census was a bubble form, like the SAT. So we used optical mark recognition software we made digital images of the forms. We used optical mark recognition software to recover the data. We didn't recover anything that was in handwriting, so we didn't recover the names. That would have been too hard in 2007. But we were good at recovering the marks. That worked well. And we released a complete count data file that's available to all in the RDCs. We released new aggregate data, and we released a new public use microdata sample. So that was a great project. I think, both of us loved working on it. We had 2 National Archives scanner technicians working down in this cave for 6 months. I spent quite a bit of time in the cave too. And it was fantastic. So I really liked working with the Census Bureau, and in 2010, I went to work there, and more recently, I've come to the University of Michigan here to ICPSR, and Katie has gone to the Census Bureau. So after a long stretch at Michigan, a couple of years ago, Katie went to the Census Bureau. And this problem has stuck with us. So we have all the data now. All the microdata is recovered from the censuses of 1960 through the present, but it's not linked. And we'll tell you about why and what the challenges are. We're close. So here's what is linked. The 2000 data, the 2010 data, the American Community Survey, that's all linked.
We don't want them to see us.
What's that? Oh, okay.
You can move the little pictures to the bottom on Zoom. So you can just grab them and move them somewhere else so that you can see the full screen.
Are you talking to me, Katie, or
we're on
someone else?
mute.
No, I was talking to the person that I think
Oh.
is struggling to see the image, because my guess is the Zoom pictures.
Honey, she's talking to us.
Sorry.
Anyway.
Okay, sorry to interrupt. So just everybody on the call, if you could just double check and your microphones to make sure you're muted. Thank you. Thanks a lot. Thank you.
That says mute.
It looks like maybe a Don Kimball has, okay, there we go. So that modern data is linked and ready to go. You can request it in your research data center. And in the meantime, I left you in 2007 and now it's 2020. It's been quite a big 13 years there, where the 1850 through 1940 data, which is public, census data becomes public after 72 years. So the 1940 is the most recent file that is public. 1950 will come out in 2022. The 1850 through 1940 data is all fully entered by collaborations through two genealogical companies and the University of Minnesota. It's all entered, coded, available for research, and linked. The linkages keep getting better and better, but you can see I've identified 2 groups now who have very large linkage infrastructures already available. So this is fantastic, but what you don't see, you see a big gap there. That's what we're talking about today, okay? How we're gonna bring all this together. So I think with that, I'm gonna let Katie tell you about our first effort to fill that gap.
Yeah, so in that previous, thanks Trent. Trent and I actually do this a fair amount together, and clearly we're pretty big geeks together because I love hearing that every single time. I still get excited about it. So that's fun. But as Trent mentioned, we had all of this data. He and I both worked for IPMS, and I was working for IPMS on this 1940 data and getting the full count data, which any of you can go use. There's a public file sitting on their website. And there's a restricted file with more information. And if you go to the next slide, I think Trent, it shows you the, from Minnesota, yep. So this one. So what we did at the Census Bureau is that the Census Bureau, while I was at Minnesota, brought in, so Trent was working for the Census Bureau then, and we brought in the 1940 data that we had with PII, with names, so that we could try to link these two sets together, so that we could link people from 1940 and going back in time to the link data that we had at the Census Bureau, so to 2000 and on. And this was really exciting at the time. We hadn't done that much with historical linkage within the Census Bureau. So how we did it is that we use the same system we basically use for modern data with a little bit of adaptation. So what we do is we have a composite file at the Census Bureau. That's how we link things that we have, and a composite file made of administrative records and survey records on individuals. So we have like sort of this big list of individuals in a highly, highly secure area that very, very few people can get. And Bryce, who's on the phone, can talk to you about that too. He can't get it, like I can't get it, like we can't even see it there. So we take this very seriously. And what we do is we take data with PII on it. So personally identifying information like name, date of birth, sex, birthplace, your address, and we link them at the individual level to our composite file. And with that composite file, we have something called a protected identification key, or a PIC. And we use that identifier to replace all of this PII on data so that it's able to be linked across data with a PIC, but also so there's no identifying information on the data that researchers see. So again, the Census Bureau takes your confidentiality really seriously. So what we're doing here is we're bringing in data, or using our data, using the information on it, but using that information to put an anonymous identifier on it called a PIC, and then you can link it into our system. And what we wanted to do was try this with 1940, right? To really bridge this gap and make this huge period of longitudinal study, which is something that hadn't been done. So, and we were nervous. So we got the complete count data from IPUMS here, and you can go to get it too. But we took it, and why we were nervous is that both Trent and I had also worked on historical linkage. So both of us have tried to link this old data, and we had done a lot of this work going back in time at IPUMS, especially working with genealogists. So I mean, at Utah, a lot of people in Utah have done this. There's other economic historians that had done it, and we generally expect pretty low linkage rates. We thought there would be about 2 million links. If we linked 1940 directly to 2000, this is what we would have. We would have name, we would have age in 1940 and date of birth in 2000 and the gender, and that's it, reported gender. However, with our composite, we can actually link a lot more to the composite with 1940. And what we add on there is date of birth. So that was in the 1940 census for everyone. And we also have date of birth in the administrative records composite that we've built. In addition, in 1940, we have parents' names when you live with a parent. So for young people, we grab their parents' names, and we also have that in the administrative records composite. And through that, we were able to link 54 million of the 1940s, 132 million observations to the administrative records composite. Now we do the same thing with 2000. Whoops, that's fine. We can go to that one. You can go next. I'm not clicking my own. So as you can see here, because of parents' names, of these 54,000, we get a lot more of them with the young people. So that's what this population pyramid is showing. The shaded darker area by age groups here are the percents that we're able to link, or the numbers at the bottom. And going up, you can see with the age pyramid, as respondents get older in the 1940 census, we link a lot less of them. So that's really for two reasons: because we have none of their parents' information in there, and also because our administrative records composite is based on SSNs as well. And so SSNs were introduced in 1936, which is really useful for us for 1940. And most people going forward, right, get an SSN at some point, either through working or through their spouse working. But a lot of the very elderly people here over 70 never got an SSN. So at any rate, back to now we have 2000, and we're going to link this to the administrative records composite. And again, we use those same things. We could have linked them directly to 1940, name, date of birth, sex, but we also have place of residence. Address is really important. So we have place of residence in 2000. In our administrative records composite, we also have place of residence in 2000, if we can find it. So, right, we have that information sometimes from tax records, from HUD, from Medicare, from other things. So this is a really important, helpful piece to link things together. So of the 282 million cases, we get about 250 million cases in 2000 that we have picks on. That comes to about 90%. So that's a pretty great rate. We put these two things together and we're able to link 26 million links between 1940 and 2000. So if we could link everyone, if we like everyone that we think is alive, we would have expected about 41 million links. So we're getting a linkage rate of over 50%. So this is really exciting to us. However, so this is great. So right now, this data is available. So any of you can come and request this data from the FSRDC, and I'll talk a little bit more about that at the end, about what people are doing with this data, because it's really incredible. We have, for a lot of people, we're able to see them in 1940, see their early life conditions, their birthplace, and then see later life outcomes in 2000. But as you know, that's a 60-year gap. So that's a pretty big gap for anyone trying to study things over time. And what we're really missing in here is 1960 through 1990 decennial data. And really, there isn't that much data between there outside of this. So there's some current population surveys that you can link to. There's one in 1973, one in 1978. There are less than 100,000 people in each of those that you can link to. There's some other administrative records during that period that are difficult to get your hands on, but are there. But in general, there's very limited information during this time. And this is what Trent and I really wanted to tackle next. And he's going to talk about that.
So between 2015 and last year, we were conducting several pilot projects on how to link these intervening years. And it might seem like this shouldn't be a hard problem. I mean, all the other years are linked, isn't it just kind of more of the same? It turns out to be a much harder problem in a couple of ways. As I've told you, we have microdata files. Those were recovered in the between 2003 and 2010, but they don't have names. Every other year that we've talked about so far, from 1850 to 2020, we have names. We just don't have names for these years because they were never entered by the Census Bureau or by us when we recovered that data. But they're available. They're handwritten on the original census manuscripts. Those manuscripts are on 250,000 microfilm reels, and each reel holds about 2,000 images. So we're talking somewhere around 500 million images that need to be made. They're not even images right now; they're microfilms. And to complicate matters further, these images are stored in very secure facilities. We're actually not using the cave that I described before. We're using a different facility in Jeffersonville, Indiana, where many of you have used secure data. It's harder and more expensive to do that work, and that's how we have to do all of this work. So a pilot project that we finished not too long ago, we worked on the 1990 census in particular. We're using similar methods for all the censuses, especially for the recovery of the names. That's really the most expensive problem that we face. So we started with 1990. And just to give you a sense of what that form looks like, this is my handwriting, but this is a real 1990 census manuscript. We're trying to capture those names across the top for persons 1 through 6, along with, if you can see at the bottom of person 2, there's an 11-digit number. That is how we link those names back to the microdata we already have. So just to kind of repeat myself, to be sure you get what I'm talking about, we're not making a whole microdata file. The microdata file already exists. We're recovering names and putting those names on the microdata file. Then we can do linkage. So we're getting names and that numeric key. This is how the name field has looked over time, just so you can see. In 1940, it was just one field. There wasn't first name, last name, middle initial. In 1990, we at least do have that delineation. In the American Community Survey, you can see that there's better segmentation where there really are separate boxes for each of the 3 names. And then in 2020, that's sort of like the gold standard. If you're going to be doing optical character recognition, you want segmentation of letters with instructions to your respondents to print. And that's what they did in 2020. So that's what a form looks like when it's truly optimized for optical character recognition. No form prior to that is as optimized as 2020. 1990 is not at all optimized. So this is just a little summary of the challenge that we face. Our form is not optimized for OCR. 2020 is. Our form is hard to get, like the 2020 census. 1940, easy to get. That means you can ship it out to anyone who's willing to try it and say, please try doing OCR on this, and they can, it's cheap. This isn't like that. The handwriting quality, anyone who's done this kind of work is probably aware it has gotten worse over the course of the century. The handwriting that was done on the 1940 census was done by enumerators. That's why I say we only have variation of there are only about 100,000 people filling out a form in 1940, because they were professional census enumerators who did it, or at least they were temporary employees, but they were people who that was their job, was to make legible entries in the census. In 1990, basically everyone in America got something in the mail and they filled it out. In 2020, almost everyone used the internet. So they were, the last time I checked, they were expecting about 20 million responses by paper. I haven't checked to see if that's what they actually got. But it's surprising but true that the volume of the problem is by far greatest in 1990. And of course, we, until recently, didn't have any money. The 1940 census was fundable by commercial interests, because there's of course money in genealogy, and there's also people who believe it's really important to do. So there was funding for that. The 2020 census digitization of names is funded by federal appropriation, not 1990. The Census Bureau does not have funding to improve old data. That needed to come from elsewhere. So those were our problems. And here's how we approached them. We tested 2 different scanners. So we rented scanners from 2 different companies and scanned several hundred microfilm reels. We made ground truth data. So we had people typing in names and the little code at the bottom of the field from 50,000 records, from 50,000 records on these microfilm reels. And we double entered all names so that we could check ensure that these weren't really data entry errors rather than OCR errors. So we wanted to have some ground truth for training the OCR and also for evaluating it later. And then we had 2 different teams. Katie and I are not experts. We're not people who do OCR for a living. We're not out there writing code on how to do OCR. We relied on other experts for this. We had a team from USC and a team from that's University of Southern California's Information Sciences Institute. Now they're at Amazon Artificial Intelligence, and a team from A2IA, which is a commercial form processing company. We set them both up on quarantined machines in the basement of the Census Bureau. That's what you're looking at here. And they both worked really hard on this problem. And they did a pretty great job. I'm going to show you what we got in terms of our OCR. For the age, this was like our control variable. Age was handwritten on the form. So you wrote that you were, if you're me, I turned 50 this year, I would write 50. OCR was able to read those numbers with complete accuracy 95% of the time. We read last name with complete accuracy. So this is a word error rate. This is if we got the word letter for letter exactly right, 82% of the time. And for first name, 75% of the time, we got the first name exactly right. This is good. This is good. It's not probably not quite as good, not nearly as good as hand entry. Hand entry is not an option here. There was no way we could get the money to do data entry by hand. And of course, you don't need perfect data entry for record linkage. So how often were they very similar? For last names, about 90% of the time. First names, about 86% of the time. And I've defined the similarity in terms of the Jarrow-Winkler string comparator here. And this is the standard. It's a pretty high standard, 0.87 or better, that our record linkage software uses. So this is, would we have considered this a name match? With last name, about 90% of the time, the answer is yes. And we also are, our output has indicators of confidence. So we know that other 10% of the time when we got the name wrong, most of the time we know we didn't do well. So we know to ignore that output. We don't know the right answer, but we know that we have the wrong answer mostly. So we mostly have good data. When we don't have good data, we know that it's not good. So those numbers are what we've, a part of the package we've kind of been shopping around to do the whole thing, do the full production project for 1960 through 1990. And Katie, you want to tell them where we are?
Yeah. So that's what, basically we came out of the pilot pretty surprised. And probably me more than anyone, I was really not convinced that OCR was going to work. And in fact, Trent just showed you the results from the one team, from the USC team, the A2IA, whatever it was, they didn't do well enough for us to even talk about. So, so we were really grateful and excited, and we felt like this was enough to move forward to try and actually do all of this. And in general, part of the reason we want to do it, the other big thing that happened, and that was happening at this time, was that this 1940 data was being made available to researchers, and this linked data outside in the RDC system. So not that long ago, like more than 5 years ago, the Census Bureau actually wouldn't let any researchers use this data linked over time, because census data, they're mandatory response data, and they found it too sensitive for researchers to be using this data. So Trent and I were both involved with the CLIP project, which was trying to get academic partnerships to do research using this data and show that this was safe. So this was really necessary. So we had to figure out if we could actually get this data, and then if people were allowed to use it. And so at the same time going on, we were sort of expanding and pushing, and now the Census Bureau allows people to use this data. I think next, and we have, so some of our current projects that are actually underway using this data, which I think might be of interest to you here. There's one looking at grandparents and great-grandparents and intergenerational mobility of them. This is actually coming out in Journal of Labor Economics, I think next month. And right now, intergenerational mobility is really hot. Trying to understand it and understand social and health implications of it are big. So this is one of our projects. Also, Trent and I were both involved with a bunch of research looking at the Great Migration and looking at the movement of people from the South to the North over since 1940. And there's a number of papers that came out, including in demography here, this one, looking at impacts of the Great Migration. Finally, we have a whole bunch of other projects, and there's more and more happening. So I'm constantly getting ones that I'm reviewing from researchers using this data, but some of them that we're pretty excited about, again, more intergenerational mobility stuff that was just coming out, and looking at even migration from other countries. So birthplace people coming from other countries and immigrants over this period, which is also sort of a hot topic these days. So again, tons of research that can currently be done with this data. And because this research is allowed, this really gave us sort of the power to go looking for the funding to do this work. So as Trent mentioned, the Census Bureau doesn't have funding to keep up historical data. It's actually not in our mandate at all. We have the National Archives to make our data available. We are just sort of doing this for researchers. And so it's not necessary to keep 2020 running like the decennial, right? It's really just for researchers. And so we're pushing this, so we sort of needed to find funding elsewhere. So right now, what we have ongoing and what we have primarily funded with foundation funding and federal sort of research funds is that we're documenting this 1990 project. It's taken a little longer than we wanted just because life, let's blame coronavirus now, but not quite, just going on. So we're hoping to have that fully documented. We're actually working to recover and improve the tax data. So when Trent was at the Census Bureau, they found full universe 1040 files from 1969, 74, 79, 84, and 89. This was a really big deal. The IRS doesn't have these files. We didn't really know that we had these files, but they were processed by the Census Bureau. And why they're so incredible is that they'll help us be able to assign these picks to individuals in the 60, 70, and 80 census. We really talked about 90 here, but all of those years have their own challenges. And especially just like going back in time for 1940, we have less information than we do with modern data. So with that information and picks, we'll be able to recover and link these censuses from 1960 to 1990. So we described this work in this working paper, and we plan to start this work this winter. So winter or spring, again, depending on COVID. And our real hope is that by 2025, 2026, that you'll be able to link all of these decennial censuses right across at the individual level, link them into any of our surveys, which you can now that have PICs. That includes the American Community Survey, the CPS. Both of those have health insurance information, and CPS has general health, American Housing Survey, the Survey of Income and Program Participation, and also Medicare records, Medicaid, and the Social Security Numerated file. So we have different administrative records that are available. You can also bring in your own data. This is something Ken has worked on with us as well, bringing in data at the individual level and linking it into this big infrastructure. And we really feel like with the spine, going from 1940 to the present and even back to 1850 with the historical data, that really makes this data much more valuable for studying intergenerational change, for studying sort of life course processes and early life conditions and later life health. So I think with that, we're happy to take questions. And obviously you're welcome to email either of us with questions at all times. We're happy to help users. Both Trent and I spend a lot of time supporting the RDC and supporting researchers getting access. I've given a talk to you all before. Hopefully you're not sick of hearing from me just yet.
Well, Trent and Katie, thank you very much. You have a high tolerance for pain, and we just want to point that out. And as I think you guys know too, that we also have our very own cave here, right here in Utah, that we also store data. That we're very proud of our cave also.
No, you have a data cave. I want to hear more about that at some point, but it's great.
Oh yeah, we. I'm not trying to out cave you, Trent, but I just wanted to make sure.
Well, the government has two. So there's also one in Boyers, Pennsylvania. So you're.
Oh, okay. So we can be aspirational with our one and hope for two maybe. Wow, it's such a huge effort for the whole country, and those of us on the call who love demography and certainly historical demography, really appreciate all the hard work you're doing, and we've been aware of it for some time, but just to always hear how it goes and how it is going. So we have some time here for if there's any questions. I actually have a couple, but I want to give others who are on the call, if they have any questions for Trent or Katie, please jump in.
Hi, I have a question. Jess Sanders. Hi, Katie. It's good to see you back. It's always awesome to hear you present, and this is it's really exciting to just see how much this has moved forward in the last year and a half. We're hoping that you and Trent could speak to the first steps in the process of getting bringing data in to be linked with the kind of longitudinal census data.
Yep. So we have a group that does this. So we have what we would do is they work sort of with our legal team and with you to bring the data, and with potentially the legal group with the data you hold, right? So we need to make sure that your data can be brought in, and depending on what you want done. So if you want it linked at the individual level in here, let's say you have a set of clinical data, you have approval to do it, we bring it in, we go into an agreement with you, and then you pay us to do it. So we have standard rates for that based on kind of how big it is, but mostly what it has in it. And we'll also talk to you though, before you go into that, about what we really think the linkage rates will be. So it depends on how much PII you have in there, right? If you have something like SSN and address, it's really great. If you have name and address, we can do a lot with it. Birth dates help a lot, right? But we sort of determine, we'll work with you to try and figure out if it's possible, and what we think will happen. And then we go through an agreement and you bring it in and you would give us that data. We would take it, we would assign a PIC to it. We would strip the identifiers off of it and make that stripped version of the data available to you in the RDC, along with the other data from the data infrastructure you request, but you can't bring it back out. So from there, you do all of your research within it. Obviously, you have the data out that you can do things with, but once it's in the RDC and that way and linked to the other data, then you have to use it in there for your analysis, and all of your results would come out, would be reviewed for disclosure purposes, and would come out that way on an approved project. Does that make sense?
So Jess, and if I could just add to Katie's response. So I'm glad you asked the question, because this has been coming up a lot because of the advent of the RDC, and it's not for the faint of heart. I mean, you do want to, if you want to do this, you know, I think it's obviously important to talk to the census side. So to Katie and others, and then Bryce is on the call here, our administrator for the RDC, and maybe you've already talked to Bryce, I don't know, but I think I would encourage this. And again, there's many of these ideas that are coming out of Utah, partly because of the medical data and having medical outcomes. And I think your question also reminds me, and the point of our getting together for this event today was to try to find the teams and common objectives. And so as we think more broadly about linking you know, any kind of health data, which a lot of us are interested in, we should probably, you know, coordinate is all I'm trying to say. So.
And Ken, can you speak to a little bit how the UPDB linkage and this, like, if that's a more streamlined way of kind of getting into the RDC, and speak to that just a little bit too, if we already have linked with the UPDB, how that might.
Yeah, so for Trent and Katie, so Utah Population Database, that's the UPDB, and I'm sure I've probably talked to you both about that over time. But so in the original RDC application, that was actually part of the application to set up the RDC to link UPDB to it. What it will be, it will not be UPDB writ large linked to and picked in the way that Katie and Trent talked about. It's really going to be by source. So we are currently underway working on a project to link all the census records, sorry, all the cancer records to the census from the Utah Cancer Registry. So that's like a data contributor. So we're not going to take like all of UPDB and try to link it. We're going to, because we have to work with each data contributor. This is, I know, a more detailed topic than for everybody who's stuck it out to this point. So I really appreciate everybody. But so that's how it's going to go with the UPDB. We have to work with each of the data contributors. And the University Hospital actually wrote us a letter of support, and they were willing to share the clinical records for this very purpose. When I wrote the proposal, we'll have to remind them that they supported us, but I do have a letter of them doing it. So in terms of the hospital records, we actually have support for this, emotional support, not financial support. So anyway, so that's we got a path forward with respect to UPDB. Are there other questions for Trent and Katie? Any others? You know, the one other point, I was just going to take 1 minute, and then I do want to talk about the grant part of our discussion today. And Trent and Katie, your field of, you know, you can feel free to stay on, but it's going to be kind of more of a local discussion. But is there a linkage to NDI in the works?
So we have, so we don't have linkage to NDI. So the NDI and CHS has that data. So
National Death Index, by the way. I'm sorry. Yeah.
Sorry. Yep. The National Death Index, we don't have that data. However, so two things on that though, so there is, right, this, there are national movements to try and be like, you know, these things changing to try and get all of the agencies to share data. So there's a chance that there could be in the future. In addition to that, I mentioned that we have the SSA Numinent data, which is the numerical identification system from the Social Security Administration. We've been taking that data and actually sort of curating it on our own at the Census Bureau for many years. And we capture death information in that. And I recently actually have a paper under review at APHA or AJPH. So maybe it'll come up there. I hate that I can't share it. But it's right now, but basically we show that the Numinent and the NDI are really tracking very closely right now, even though they have slightly different universes. So the Numinent only is for SSN holders, but we also capture deaths outside of the US, where the NDI is really focused on deaths in the US by anyone, but doesn't actually capture US citizens dying elsewhere. So at any rate, we think this data is really underutilized right now. So we do have some pretty decent all-cause mortality data, but no cause of death data.
And Ken, you may know this, but there is one, the National Longitudinal Mortality Study is available in the RDCs that links a bunch of current population survey data to the NDI. But that, I mean, that product alone shows the challenges of doing it on this scale. That is a very expensive long-term project for just an itty bitty, you know, it's one current population survey rotation group each year, or maybe it's 4 each year, but it's not that many people. To do it for all these people under the current mechanisms of getting data from NDI would be many, many millions of dollars.
Yeah, I was hoping for the answer that, oh, we've already done that, but I realize I realize there's a lot of work to be. Yeah, I recognize that. I just and I know there's another. Is it MDAC? There's
MDAC.
another.
I was going to say that too. The ACS link to the death records too.
Yeah, and that's another RDC accessible data set.
Mhm.
But okay, I think what I'm going to do is, I know we're getting into some details where maybe not everybody's interested in this topic, so I will just say thank you to Trent and Katie for coming on and sharing all the work that you're doing, and I'm sure there'll be follow-up emails as always, and you guys have such a you know, collegial philosophy about all of this anyway, so you can look forward to some follow-up that way. So thank you again, I appreciate it.
Thank you.
Thanks, Ken. This was great.
Okay, thanks again.
luck, guys.
Bye-bye. Okay, hey, I see that Cindy Brown has joined us, and I asked Cindy, and actually, we're going to just talk a little bit about grant strategies. And so I'm not sure if everybody knows Cindy, but Cindy, would you just mind introducing yourself? So
Sure.
if there's a few people here who don't know you.
Okay. I'm Cindy Brown in the Office of Research Administration, which is through the College of Social Behavioral Science. And our group is here to help with pre-award and post-award grant management. And so today I just wanted to share Pivot. I don't know if anybody's heard of that already, but it is a comprehensive database that's offered to the university where you can do searches. You actually enter your profile with your keywords for research, and you can ask it to really advance down your searches so you can pinpoint exactly what you want. And when things like that do come up, it'll send you an email for you to like check it out. In addition to looking for funding, you can also find other researchers, not just within our institution, but other institutions that do the same kind of work. So it's a pretty robust database, and one of the best that I've seen.
Can I just ask the people, how many, maybe you could just use your reaction button. How many people are using Pivot now? Or maybe you could just raise, well, some people aren't on camera, but okay, I'll put my thumbs up again. So
I mean, I get the notices and I look at them. There's some issue with the way that I'm in the database though that has made it difficult for me to narrow and select topics. But,
yeah, so thanks, Tom, for that, because I think that's not an uncommon experience for people who get these Pivot announcements. So originally, Cindy and I were going to have a list of potential funding opportunities that fit within our topic today on disparities and inequalities and stratification and poverty. And it turned out that first of all, there's many of them, and some of them are quite esoteric, and some of them are just, you know, the matching is not all that good. So in the end, I felt like it was probably not going to be a good use of our time. And I thought, that's why I'm glad Cindy's here, because we thought it'd be better just to enable everybody on using Pivot. And I think so I would just maybe make this general comment. Number one is that we're trying to encourage everybody to get registered and activate your and I guess you claim your name. I can't remember what the term is, Cindy. You have to, anyway.
Yeah, your profile. Set up your profile and claim it. Yeah.
You claim it, okay.
Yeah.
And it is a profile, so you can tailor it to your own specifications for things that you want to be notified about. And so, like in Tom's case, he may be getting you know, a lot of just false positives that are coming his way, and to the point where you don't even want to look at a pivot email because it's wrong so much of the time that it just defeats the purpose. So
It's also, I mean, if I could, Ken, if this is helpful, the issue that I think I had is that they're integrated with ProQuest or something. And so there are like profiles that I have from the past that have forgotten IDs and passwords connected to them, which make it difficult for me to use the sort of personalization stuff that Cindy's talking about. So maybe that, you know, I haven't had the energy or time to follow up on it, but that's part of the issue.
Okay. Okay, that's now beyond my pay grade, but with respect to pivot. So
yeah, I had a similar experience where I had to merge two accounts, but yeah, it is a bit of a hassle.
So Cindy, what do you recommend in this case? Is it you, or is there somebody else who can better help on pivot to clean up this kind of nuisance?
Yeah, I don't think our office is meant to do that, but
is there an office that does?
Well, sponsored projects. It used to be Jesse Morris that was in charge of it, but I'm not sure if that's still his role. But yeah, they know a lot more than.
Maybe one result of this meeting is if you could make a find out who is the official. I don't want to send people to an unproductive referral, but if we can just find that out. Okay. So that understood, and then so we want to get people on the pivot, and then obviously set up your profile, and if you can clean up some of these merging and past account issues, that obviously is another. And then the other thing is that you can, there used to be a thing called Find a Researcher or Ask a Researcher, which I think is being decommissioned, or at least it's certainly not being supported. It might still be out there. It turns out it gives you way too many false positives. So the other option here is to use Pivot as an alternative, as in fact the go-to place. And I think I would just say this in general, from a Nexus standpoint, just if you want to find other people, that's like a super simple way to do it. And so I just want to make sure everybody's on Pivot. And the other thing I would want to mention, I've got just a few other points, and then I want to kind of just open it up for some discussion. But from a Nexus standpoint, there's Pivot, but there's also, and here's the, I'm going to slip in an infomercial now, in case it won't be painfully obvious from what I'm going to say, but I hope everybody is a Nexus member. And so if you go on the Nexus website, if you're not, it allows you to apply for a pilot grant program. We've had 2 rounds of that. And it's just also a way for us to help you connect to other people. And so we would just kindly ask if you went to go to our Nexus website, and maybe super obvious if Austin's there, maybe he can just put that in the chat, just the Nexus website. But anyway, right there is a place you could just ask for membership if you're not already a member. And if you're supervising students, we would encourage them to also join also. So, and then the other just a point I wanted to underline. Some of you hadn't joined yet when Dan Reed was giving his remarks, and one of the reasons that we wanted Dan to be on the call is that and he alluded to it, but he didn't quite announce it. So I'm going to repeat his not quite of an announcement, which is that he has some initiatives to support work on disparities and inequality and diversity. And so some of you heard, who were on the call at the time, that there is going to be, they're looking at a pilot grant program. And I understood it, and Rick, I think I maybe have heard, Rick Forster, I may have heard this from you, but that it may kind of rival the support that was done for the COVID-19 projects, of which there was over $1 million internal dollars to support that. Anyway, maybe I got that wrong, but it's at this point, it's not official. So I will just repeat that caveat. It's not official, but I know. So Rick, do you want to comment on that at all?
Yeah, I hadn't heard too much more, and I hadn't heard anything about the magnitude myself, but Dan's mentioned it at a couple different meetings now, and
Okay.
and I imagine if he's talking about it, it would be substantial.
Yeah, and I just hope it happens. I know you know, that like anything of this magnitude, it's going to take time for them to organize it and roll it out. And so I just want everybody on the call and people you work with just to be ready and just have your antenna up for when this officially gets announced. And then I would also, just to stick to Dan's comments for another minute, I do think I would like to ask you and your colleagues that if there is going to be another TEP kind of, you know, a cluster hire to be, you know, to be thinking about people who, if that actually rolls out, to be thinking about people and the nature of something like that, that you might want to recruit to come here. Obviously, it's not an official announcement yet. He's just looking into it, but I would just want to kind of get it on your radar to start thinking about, oh, you know, just have that fantasy moment. We don't get very many fantasy moments. Have one, just take one. No one's going to keep track and think, oh, I would love to get Jane or Joe Jones to come to Utah. You know, so I would think just over the horizon a little bit and think about something that you thought maybe would be unreachable, but maybe with enough resources, they could be attracted here. Oh, and my other, I just want to make sure I underscore what Cindy described herself in terms of pivot, but I also want to mention, and I think maybe everybody on the call knows this, but for those who don't, who haven't worked with Cindy on working on grant proposals, so in terms of getting stuff out the door, getting budgets together, not the actual writing of the grants, but the preparation of the proposals. You know, Cindy is partnering and is really connected to Nexus in this respect. So Cindy is a resource for that. And I think Cindy has a very large portfolio of projects that she helps get out the door. And I think it's been quite demonstrated that Cindy has been great. I don't know what fraction of all F&A we can attribute to Cindy Brown, but we're going to say not trivial. And so let's embellish her record by doing more grant writing and working with her. And then we also have Jesse Morris, who some of you know, who can help with also more of the actual narrative of the project, of your proposal. Those his role has changed somewhat, but that, as far as I know, that's still his official title and responsibility. Okay, so we are down to the hardcore people. We actually had breakout groups that were going to be planned, but we may be the breakout group who are here. And so maybe I'll just I'm going to call an audible and mention that that I really, since you guys have stuck it out to the end, you must be, you know, you must love this topic. So are people working on a particular project or want to work on that you want to share with the group? That just take a minute or two and have people just discuss that, or I'm just going to kind of open up for anything you want to talk about for any topic we've covered today, including what the speakers talked about. Anybody, did the link census stuff grab anybody? Tom, I would think you would be the first to jump in line.
Yeah, I mean, there's just I've heard some of this stuff before, and certainly following kind of Joe Ferry's engagement in it, and so it's. But I came in very late. I had a dissertation defense this morning, but I don't know whether they talked about this. There's another sort of project that's related that's linking historical censuses and has actually set up a sort of an interactive website where you can go and say how you would like these things linked, and they have these various AI algorithms that are that'll kind of customize it for you. So there's just, I mean, my experience is there's so much going on there, and so much through like the SSHA kind of networks that I'm just still trying to kind of get my head around the opportunities.
Okay. And Joe, did you raise your hand?
I didn't raise my hand, but I'm listening.
Oh, okay.
Carefully.
I think when you did this,
Did I do this?
I confused it with you raising your hand.
Okay. Yeah, but I'm very carefully listening. So.
Okay.
So I would just add one thing in terms of talking about Dave Wetter's work, that one of the resources here locally that the university probably hasn't exploited as much as it could is, especially when dealing with economic and social disparities, and that is United Way here in Salt Lake City. United Way of Salt Lake is very invested in data collection. I was just on a Zoom call yesterday where they are moving their 211 system, which is their when you have an emergency, a social emergency, social economic emergency, that is the number that you can call to get resources. They are moving from a call-based database to a client-based database. So they're going to be tracking people longitudinally so that you can identify people who are chronically in economic distress and coming back to 211 versus those where it's very much a transitory situation. So it's, you know, like a college student who's temporarily in need of some resources. And so I just want to put that out there as you're thinking about projects on socioeconomic disparities to think about resources. United Way is also heavily in Title I schools and doing a lot of work. And again, they're very data driven. And so I don't know that, it occurs to me that we have not capitalized on the fact that we've got data in the Utah population database on families, but linking it to something like what United Way is doing would create richer histories of socioeconomic disparities in the state. So I'm just going to put that out there.
I'm sensing people are running out of gas, and so maybe my parting shot would be that, and I think you've heard me recite the mantra about Nexus, is that as you are trying to organize grants and proposals and projects, and you need the some organizational help in terms of just now we do everything on Zoom, but one of these days COVID will be behind us. But anything that's organizational, certainly working with Cindy on preparing budgets and grant proposals, sharing ideas, getting students involved, all of the kind of nuts and bolts is what Nexus is here to do, to help. And then I know Bryce told me he had to step off to make a 2 o'clock meeting. Oh, I was going to say something about RDC, but maybe Kim, if you have a comment. I was just going to make one comment about RDC, but go ahead.
I guess I'm thinking ahead. So like just where I come at, I feel like right now with a couple of other projects, I can't really hop on something that seems to me at this point, at least, quite US and locally based. And my interests have been much more overseas lately. That will sort of rebalance at some point. But thinking organizationally, as far as resources, that could be beneficial. I think, and especially when we can be together in the same place, perhaps some sort of like working groups, maybe a sort of short retreat where people would get together and brainstorm ideas that would be very much focused in the data. personally, I think it would be great to see some more initiatives that are also not only the socioeconomic disparities, but thinking about some of the equity, diversity, and inclusion issues that are on the forefront of everyone's mind, especially maybe long-term effects of COVID-19 on, different racial and economic groups and their sort of socioeconomic trajectories, and what's going on with their families. I'm guessing that there's something that we could do as the data is that it's more in the past for us. And then also thinking about immigrant and refugee communities, those are the kinds of things that I would be interested in. And I just think generally the idea of pulling people into working groups and having some sort of, process where we're doing project or proposal development, that's the kind of thing that I think would be helpful. And I think it's been helpful in other units like CFAR and, Center on Aging and that sort of thing.
Yeah, absolutely. So I want to make a general comment and a very specific comment. So the general comment is, in a way, this gathering today was sort of the start. Really, we kind of lit the match on social disparities and trying to get people together. So we have a list of people who responded. We have a lot of invitees, some of whom did not respond, but we already have a list that is this domain. Now, this is a very big domain, so we'll probably have to, even from this area, we're going to have to break out to the subtopics like you're describing, Kim. And then there are other things that are totally unrelated to social disparities that we're also trying to support as well. And but I think you described the to borrow a term from biology, speciation. You want to kind of launch something that wasn't there before, and that's kind of what we want to do. So if you feel like you have your own group, we have no claim on how you conduct your work, of course, but if you want to be able to have the organizational hub and help, and we've got Austin's on the call, and Austin's awesome in providing this kind of support. So that's something that we would do. So we would appreciate if you would let us know as you're ready to kind of launch it, and we can help do the organization. The other thing
Can I interject on this
please,
point that
please.
Kim brought up? So I also like the idea of these working groups. There's obviously a need for some critical mass around like a more focused topic than just kind of the broad field of social disparities. So in terms of the initial signups, was there one or two of these more focused topics that there was a lot of interest in, or was it pretty much scattered and small groups?
There was, okay, so we didn't pilot our checkbox questionnaire. And so one of the things that happened is people tended to check everything. So, but people checked everything. So that should tell you that those 5 topics that we included: neighborhood disparities, we had COVID, we had race, ethnicity, we had the digital divide in education, and I'm blanking on the 5th one, but healthcare access was what it was. And so I think what I think, having seen what came in, we're gonna try to do another poll of interests. But you should. I mean, that's just one thing we're going to do. I would like people to also have it be from ground up. So if people have interest, if they want to kind of put something together on a particular topic, I've been pushing this thing on neighborhood inequalities, and we had neighborhood inequalities got picked by a lot of different groups, and I think that's something where we can do a lot, and even in there's a lot of things that you could pack into even that topic. But so I would just say yes. Let Nexus help organize and to refine any of these working groups that we want to promote and help resource if we can. The very specific topic I wanted to mention to everybody, because because COVID-19, of course, keeps coming up, and it will be with all of us. But I don't know if you all are aware of the pulse surveys, PULSE. So this is I'm telling everybody, anybody using the pulse survey? No, okay. So, and maybe Austin, while I'm talking, if you could just look up pulse and I won't attach any names to it. And census.
Not being recorded. I'm taking hand notes, and if there's any question you prefer not to answer, that's fine.
Hey, Joe.
Is this okay with you?
Yes, that's all good.
Hey, Joe, you're
Okay.
not muted. Joe, you're not muted.
I have background questions, Doctor, but I don't think I need to ask them because I've
Ken, I think you can mute it if you press participants. You can mute his microphone.
How do we?
If you're the host, you can mute him.
everything except for this.
Okay, hold on.
What is your current
Hold on, sorry, I'm
role
trying
and
to find.
responsibility in?
Oh, there it goes. Okay.
Don't-
Wow. Good to hear from Joe. Yeah, so I started to ask maybe Austin if you could just find PULSC and then COVID-19 and census or something. Anyway, maybe you've already found it on your own doing it, search yourself. So this is a special survey that the census has been doing. And oh, there you go. This is public use data available on the impact of COVID-19 on us. And it's already available. So if anybody's interested as social scientists or people are interested in disparities in general, I haven't worked with them yet. It comes up a lot in our RDC meetings, and I would just want to make you aware of it. And I think you can even get September 2020 data that was collected in September 2020. So it's a very clean survey. They couldn't get it too complicated because they didn't want to do a lot of post-processing of the data, but I'll just mention the Pulse survey. And I'm now actually seeing some papers, working papers coming out of data that was just collected a month ago. So I would just mention that. And then it looks like, Becky, do you want to just comment on the thing you just put in the chat?
Yeah, in the chat, sorry, I had to go a couple because the link didn't copy, but Robert Wood Johnson Foundation has a call out right now if anybody has a project in this area that they're looking for funding. And I just linked it there. Letters of intent are due November 24th, but it's called Policies for Action, Public Policy Research to Advance Racial Equity and Racial Justice. So if anybody's ready to go for a project, I know I keep getting from the foundation people saying, like, do you know anybody that wants to apply for this? So I can also connect you with Lynn Wong in the foundation group that is wanting to support somebody from Utah to apply.
Okay. I will. So the other, I know there will be this and that's here and there. Oh, actually, Kim, do you want to take the mic to just elaborate on your point here?
Oh, it's sort of a minor point. So the last round of TEPs that went out a couple of years ago, I had put in a sort of slapdash last minute proposal that was concerning immigrants, built and neighborhood disparities and sort of built environment ideas. It was the effort there was, of course, to build connections across colleges. And so there was a tiny bit of connection with health science. It was with some communication with folks in architecture and urban planning. So it's just to sort of say if that sort of neighborhood context and disparities is something that does come up and TEPs are, reinvigorated, that there would be, something to go back to as a very sort of, crude starting point. It's going to be, potentially different people now because it was probably, I don't know how long ago that was when the TEPs I think certainly while Ruth was still SVP, so like 4 years ago, maybe.
4 years ago, yeah.
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 So anyhow, I think it's good to revive those, right?
Yeah. And I think my understanding about the TEP, if it gets revived, I think it's going to not. Well, I could be wrong about this, but I don't think it's going to be a wholesale all comers topics. I think they're going to try to drive the domains and then have people propose what they want to do in that domain as opposed to just whatever. I was on all the review committees for the TEPs and we saw soup to nuts, and it was very hard to compare them. And but CFAR, for those of you involved with CFAR, that was the one in the very first round, and I think everybody agrees that has been the success story. I don't know that we could say that for all of them, but that one has been really productive and
As has society, water, and climate.
yes, okay, and that one I'm not as close to, but that one also scored high when we reviewed that. So the other, and I can send you, in fact, sorry, Austin, I keep throwing stuff to you because I'm just going to be talking while you throw stuff on chat. Can you just find the Templeton? There's the Templeton Flourishing Call, Templeton Foundation. So for those of you, I'll just take 30 seconds to mention what this is. Templeton Foundation, what some of you may know about, and some people in our college have received money from Templeton. Money they're going to award about 40 million over the next 5 years in this area of human flourishing, which I've only in recent months have come to appreciate this word, flourishing. It's actually, there was an editorial last year in JAMA about health and human flourishing. So it's just this very broad concept of doing well in all the domains of your life. And so the Templeton Foundation, if you know it, they're a little kind of hard to pigeonhole they're very humanities oriented. So that takes me out of my comfort zone, but flourishing is something that they want to promote, and they're looking for ideas. And I think there's a November 11th deadline for ideas, and then they're going to cull through all the ideas, and then they're going to put out a call for those that they think are the ones that they want to go on to support, and then you can write an actual proposal. But if you have an idea, and this is like, think just big, think super big, nothing you'd ever write to NIH or NSF about, just super big, that has to have kind of a humanities and well-being and awareness and consciousness and these kind of hard to measure concepts, but certainly this flourishing concept, and but have it be a rigorous scientific phenomenon. So anyway, it doesn't take long to write a little idea. They have a little format you can fill out, and I was on a conference call the other day. Cindy Berg and I were both on it, and there were over 600 people on the Zoom call. And it was the fourth one of these informational Zoom calls they had done. So they're going to get a lot of ideas, and whether your idea might come through. But anyway, it looks like Austin has put in the link, and it's if you go there, there's the flourishing topic. So, okay. And Joe, welcome, Joe, I know you came in late, and sorry, I know how it goes.
No problem. Thanks.
And we are recording this, so we'll put this out on Nexus, and so if people want to replay it, they can. And okay, thanks everybody for staying on to the sweet and bitter end. And I hope this energized you on a Friday afternoon. And I hope to hear some follow-up from some of you on anything that was discussed today. And I would make one parting request on the social disparities and the dialogue on disparities. I just consider this to be our first date, and I'd like to have multiple dates with all of you and others on different topics. And if you want to invite a speaker, or if you want to be the speaker, I want to kind of have this be a regular, at some unknown interval at this point, but a regular gathering. And so I would just write me if you have ideas for yourself or nominate others. So, okay. With that, I want to thank everybody for staying on for so long, and I hope you got some benefit from the two presentations. And I think, having Dan here just helped us reinforce with him that we're serious about this. So, okay, thanks everybody, appreciate it. Hey, Austin, could you capture the chat box? so we don't lose the chat.
It saves everything, so.